Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome. I'm here with my new friend, Dr. David Berg. He's the president and co-founder of Redirect Health, which he founded in 2013. He's also the author of The Business Owner's Guide to Ending the Fight with Healthcare. He runs clinics and he's run clinics, I guess, in Canada and the United States. And we're going to talk today about the innovative way he's disrupting the healthcare space. So, David, thanks so much for joining the show.
So nice of you to have me. Good morning.
Well, let's just get right into it. I guess the first question I have is you've run clinics in Canada and the United States. That's an unusual combination because people think, well, those healthcare systems are so divergent. How could you possibly run a clinic in Canada? I mean, were you running them simultaneously? So did you have the same business model in two different countries?
Well, not the same time. I moved here in Phoenix in 1995, and I practiced in Canada from 1990 to 95. So we moved down here, we start all over again. And you are right, it is very different. And the healthcare is very similar, but how you pay for it and how you connect with the payment system, the bank essentially is tremendously different between the two countries.
Yeah, and you're a chiropractor by training.
Yeah.
And so
Yeah.
How is that different than, I mean, I haven't spoken to many chiropractors. How is it different than a primary care physician, for instance, as far as the healthcare system within Canada versus the United States?
So let me address how Canada is different. That's probably the easiest part.
Yeah.
Or less obvious part. So in Canada, there's healthcare, and then the payer is the government for the most part. So you have a healthcare system that's made up of healthcare and the payment system, which is the government. So the purpose of that entire system of healthcare and money is to really, the money's in charge, just like it is in the United States. So the purpose is to do what the government wants to do, and which means to keep people happy. And so in Canada, the people are quite happy with their healthcare plan. Sometimes when they need it, quite often when they need it, they'll find that there's not enough there. But before they need it, they're happy. They're at peace with it for the most part. They're not afraid of it, at least. In the United States, we have actually more healthcare and better healthcare than in Canada. And ask any rich person from anywhere in the world where they come when they get cancer or have something important they need to deal with. They all come here. So let's not argue that point. But the payment system in America is quite complex. And for the most part, though there is some government with Medicare and Medicaid, really it's the big insurance companies that control the money here in healthcare. So the system of healthcare, money and healthcare, is really here to serve them, the folks that supply the money. So it becomes a shareholder system here, where in Canada it's more of a government system. And the biggest difference I see because of that, in Canada, people are not afraid of the healthcare system. In America, many people are afraid of the healthcare system. Mainly they're afraid of cost and access that's limited by cost. In Canada, they may be a little bit concerned about access that's limited by lack of resources, but they're not concerned about the cost. So it's hard to know what's better. Having great healthcare and being afraid of it all the time, or having not so great healthcare or limited healthcare but not knowing any better and being at peace. Those are the biggest differences I discovered. Another difference that my wife and I discovered from Canada is we were very used to the concept that you would not worry about healthcare, number one, like I mentioned, but you also, if you were an employer, you just believe that everybody in your company had access to healthcare, and there wasn't this burden and fear of my child breaks their arm, that something catastrophic financially was going to happen. In the United States, it was really hard to get used to the concept that it was okay only to cover 50% of your employees or 20% of your employees, or it was, but not their, or them, but not their families. Right. Or that I'd have employees working for me where there's not a chance they could afford healthcare for their families. Even if I gave them the insurance, that they couldn't afford the deductibles and the co-pays out of pockets, right? So in the United States, it was somewhat commonplace. It's even more commonplace today. But in Canada, that was like not even a consideration that would be okay. So there's some differences around there that we had to get our heads around. And it's probably why we created Redirect Health, is because we couldn't get our head around that difference of, it's okay that I only make sure that 50% of my employees can afford healthcare. That's still a hard concept for me to get, that Americans are accept that. In Canada, that's not an acceptable way of thinking.
Well, I mean, just like in Canada, you say people are accepting the fact they have limited access sometimes to healthcare. If you don't know any better, it's just a system you grow up with, right? It's like
That's
you just
what it
get
is.
used to
Yeah.
you get used to the weather, you get used to there being mountains in the background, or there not being mountains where you live, right? That's sort of just, it's your environment you grow up in, part of the
Exactly
culture.
right.
Yeah. And it's interesting too. I've never thought about the fact that in Canada, of course, the employers don't have to worry about providing healthcare for their employees. And so that's just not even part of their, I suppose, business plan in many ways, right? They just,
Yeah.
and where
Oh, we
it
whine and
has to be,
complain about it. We whine and complain about other things, but it's not the healthcare.
right, very politely, and always complain about the process, right? Yeah.
Yes.
So, uh, um, all right. So that sets the background, obviously, for why you created Redirect Health. And right now, so I guess, you created this healthcare plan. What problems are you looking to fix? I mean, you kind of touched on, I think, a little bit, but what were you looking to? What do you say? This is the deficit in the market that we need to fix and make, improve for employers to help with their employees.
Yeah, this is where I have to be a little careful, because sometimes old people on Medicare, disabled people on Medicare, or poor people on Medicaid will go, "He doesn't care about." No, it's not it at all. I care a lot about old people and disabled people and people who don't have any money. I do. But this healthcare program that we created is not specifically for them. It could help them, but it's not designed for them. This is designed for small businesses. This is designed for our business. We had 54 families in 2008 when we started this. Now we have about 250, 260 families that we take care of. But it's designed for us, essentially, small businesses. And we have about 1,000 small business clients. We have no large business clients. We have no governments. It is a small business play. And we see it as we built this for ourselves first, because there was nobody else in this market. There's nobody else taking care of us. There's nobody else cared about an insurance product or something that would alleviate our healthcare concerns. When I say our, I mean mine as a business owner, my family, my employees, their families, doctors who worked for us who were making hundreds of thousands of dollars, or the people who were entry-level positions, the young people just starting their careers who might be making $15 an hour. Right. Mm-hmm. So that was our business family. It is our business family, and we want to take care of our entire family, not just the people who make a little bit more money. So there's no product out there that will take care of that today. So we set out to create a brand new system for ourselves with no thought of ever commercializing it. This was just for us. I wasn't going to commercialize it, and I was just trying to solve my own problem. As we talked about earlier, you became an engineer, or you finished your engineering degree. I started in engineering and went into the healthcare track, but I just saw this as a problem that needed to be engineered. So, and the determination I made is that it required a system view, a system thinking, and a system redesign. So I redesigned my system. I re-engineered our system, and it's evolved over the years into something that works really, really well. But it's very specifically designed and managed to serve the small business and their employees and the families of those employees and everyone in those families and every one of those employees. And it works really well for that purpose.
And you would say the problem you're trying to address is you have employees who don't have a lot of resources. Oftentimes you have small businesses that obviously don't have millions of dollars to throw to brokers. They're trying to deal with, the only options oftentimes are these large package plans from a healthcare provider in town, which have high deductibles, a lot of out-of-pocket costs, co-pays, expensive prescription medications, and those sorts of things, right?
$15 an hour, $20 an hour, $25 an hour, $30 an hour. You don't have
you're not going to be
left over. You don't have any money left over after groceries and rent and car payments and daycare now. And this is a problem that we're just burying our heads. We're burying our heads in the sand in America about this population of people. If you work for a big corporation or a government, it's highly subsidized. But you work for a small business, there's no extra money for the majority. I'll give you some real quick stats. If you look at the Social Security Administration stats, 51% of American workers make $15 an hour or less. Now, go to small business, you're closer to 90%. That doesn't mean there aren't people who make some money, but it's about 90% of the small business worker makes under $15 an hour. And if you don't believe that, then go to $20, and then it's a non-argument. Doesn't really matter. You can't afford healthcare at 20 or 15, and so that becomes it's a reality. If you want to work in a small business, you better be healthy and not need healthcare. You better. But what happens is it forces people to work in jobs they don't want to be in. They work in government jobs where because of healthcare, or maybe the healthcare of a child, or fear of the healthcare that they might need in the future, or a big corporation. And I've seen so many folks before we created this system in my business who went and worked for a big corporation or a government job for no other reason than my benefits sucked. My deductibles were too high. I couldn't subsidize their children's healthcare. Today, it's a non-issue because we've got healthcare costs so reasonable, so low, lower than they've ever been, as low as they were 15 years ago. And we just give it away for free to all of our employees, all their family members, and we pay for the copays and deductibles. It's just because we got the cost so low, we can afford to do that. But that is the first step, is to get the cost down. And there's no way I know of to get the cost down than to build a system that eliminates unnecessary activity and unnecessary spending. And activity is not just healthcare. It could be paperwork. It could be driving to the doctor's office when you could pick up the phone, right? There's the activity is a broad term. But also could relate to an MRI. If you sprain your ankle, do you really need an MRI in the emergency room tonight? Well, that comes with a $5,000-$6,000 bill, maybe 10, depending on how good the hospital it is at finding your wallet. Or can you wait the next day and put some ice on overnight, wait the next day and get an X-ray for $28, right? So those are the types of things. The system we built makes it much, much, much easier for people to manage the uncertainty and fear that would cause them to go to emergency room for a sprained ankle and get a surprise $6,000 bill. Maybe they have insurance, but they still have a $5,000 deductible, versus help them control that fear and understand what's going on and understand the urgency isn't there for tonight. And let's get in the morning, the X-ray. But if it gets worse, just call us right back, or just text us right back and we'll jump right on it. But it's just very logical approach to managing the clinical needs of people, the financial consequences of those needs, and managing the fear of both. The fear of the financial consequences and the fear of the clinical need. It causes all of us to do crazy things. All of us, when we're afraid of money and afraid of the health, especially the health of a child, we do crazy things. And sometimes a crazy thing is run to the emergency room. The most common thing I hear in an emergency room is sinusitis. What the heck is emergency room going to do for sinusitis? But that's fear driven. And we do have an economy of fear when it comes to healthcare in America. Yeah. Let's be straight with ourselves, right? That's what drives so many of the decisions, that drives so much money and drives so much shareholder profit, is the fear that we're able to put into people, unfortunately.
There are no shareholders at nonprofit hospitals. We know that, right? I'm kidding, of course.
Except all the VPs and the leaders that have some pretty nice salaries. I would call them stakeholders, maybe.
Yeah, stakeholders. Yeah, it is funny. You could never tell the difference in a for-profit and nonprofit hospital for the most part in the United States. You mentioned a couple things there. So I think to unpack. One is you have patients who are making that decision, going to the emergency room to begin with, right? I have some sort of crisis in my family. It happens at 7 p.m. It never happens, during business hours, right? So you can't get to your doctor's office, right? So you have to have some sort of 24/7 coverage where people are going to say, okay, we'll see you tomorrow morning. This is not urgent, or, crushing chest pain, go to the hospital. If it's not that, we can handle it the next day, right? I mean, that's generally primary care, but you have to have a good call service. You have to have some sort of relationship with someone to make that work. So you must have that as part of your plan. So how do you get that part to work with your plan?
Oh yeah. So it's a complete system, and we have to collaborate with the healthcare community all over the country. Our clients in all 50 states, all small businesses. So we have to be able to collaborate intensely and communicate with the healthcare community, meaning hospitals, anesthesiologists. We've got pharmacy benefit manager we work with. We have lab contracts. I mean, we work with every aspect of healthcare in every state in America. And communication is a big part of that. And technology is the best way to communicate today. Letters and smoke signals are long gone. So now it's about technology. And the thing that's really important too is this bi-directional, so two-direction or two-way communication 24/7. And for us, English and Spanish, we've got language lines too, so we can do other languages. But English and Spanish are the easiest for us. And we have to be available with all the records and the data in front of us. That is just a critical part. And then we have to communicate with each other inside our company. So yes, you're right. The communication platforms that we use and integrate into the entire system have to be always up. And if Facebook went down for 5 hours, I don't know what we would do if our system went down for 5 hours, because we count on it intensely, and our members count on it. And the doctors that we're working with across the country count on it also.
All right. So you mentioned the doctors that were working with you across the country. And so obviously someone has to answer that text from the patient saying, I sprained my ankle. I need, it really hurts badly. Do I need to go to the emergency room? Someone's got to tell them to not go there and get the MRI tonight. So how does that process work?
Well, two ways. One, they can call or text, and we have an operator who's trained to escalate it to the appropriate person, middle of the night or middle of the day, doesn't matter. The most efficient way, and the way most of our members would do it, is they'd go to our app and they would say, I have a medical need. They'd answer a couple questions on the app. They would tell us a time they'd like us to call them back, which could be immediately, or it could be 4 o'clock in the morning, or it could be right after work at 4 o'clock. We really want our members to tell us what's the most convenient time for us to get back to them. Now, there are occasional times when somebody will tell us they have chest pain or shortness of breath, and say, call me back tomorrow morning, and we'll go, nope, and we'll just dial. It'll get escalated fast and we'll dial. But that's what they're paying us to do, is to manage their health plan, which means their care and their money. And that's an important part that is really not Canadian to talk about the money like we talk about. But we have learned that if the biggest obstacle to access to care, meaningful access to care in America, especially for people who are making $10, $15, $20 an hour, is the money and the fear of the money. So if we can deal with the money and the fear of the money, particularly the fear of the money, we can do healthcare much more efficiently. And there are folks that won't take a statin because they believe the statin costs $180 a month. And the truth is, it does cost $180 a month at a big pharmacy.
Right. Yeah.
You go to Safeway or you go to a grocery store, it's $5.69. But they don't know this, and their doctors don't know it. But we take responsibility for the cost of our recommendations. If we give a recommendation that's world-class, but the cost is not reasonable for that particular member, that patient, that's on us. That's bad on us for not asking, can you afford $50 a month? Can you afford $5 a month? And not figuring out a solution they can actually afford. A long time ago, we got rid of this concept of it's the patient's job to be compliant with our recommendations. We got rid of that so long ago. That works when everybody makes a lot of money. It works. But when normal people who make normal wages, I just told you 90% of workers in small business make under $20 an hour, probably less than that. It's our job to create a treatment plan that will comply with the clinical needs, the fear needs, the money resources, the time resources of our members. It's our responsibility and our team's responsibility, our company's responsibility, our system's responsibility to comply with those things. That's how we've turned it. And I know it dramatically improves the healthcare, at least to these people. And sure. Quite often when I get into a mixed crowd or a crowd where the people we serve aren't in the crowd, it's sometimes hard to understand for somebody who makes a lot of money. I know you understand, because it's a little easier for a physician because we work with those people, and we waive the bills all the time and sometimes we do services for free because there's not a chance that single mom who works at Wendy's is going to be able to afford that $2,000 or $5,000 deductible, which is how we get paid. And it's just easier just to let it go. I mean, every physician in the country does that at some point.
So one of the excuse me, one of the concerns people would have listening to this, they say, well, okay, so there's no cost to the employee for the most part, for most of these, no copays. Wouldn't they just overutilize healthcare? Right. That's always when you ask people why healthcare is so expensive in the United States. What the answer is, well, people are detached from cost, which is somewhat true, right? You have patients who don't see the cost, and you have physicians or hospitals that don't, they can the person paying is not the one in the room.
I do understand that's a narrative.
I understand. Yeah. Right. So how would you dispel that?
That's not how I've experienced it. So
yeah.
One of the assumptions that we often make, and I heard earlier in one of your comments, was that there's this assumption that people have doctors. The people I'm talking about, the vast majority of them do not have doctors.
Right.
So they use urgent care as an emergency room. So why would they go to the emergency room? Because they don't have any other means, right? They don't have a friend they can call at 7:00 at night like you and I do.
Right.
They don't have a doctor they can call in the morning, right? They just don't have it. They have an urgent care they can go to right now, or they have an emergency room they can go to right now. But then they have to deal with the consequences of the unknown bill, and it's fearful for them. So that's the first assumption that's wrong, is that people have doctors, that people have all the ways that you and I have to go interact with the healthcare system. They don't. The vast majority of Americans, even if they have insurance, they don't have doctors as easily as accessible as you and I have it. So this concept of overutilization, yes, it does happen. But the real question is, how much does that overutilization contribute to the overall cost of healthcare, to that $700 premium, to that $5,000 deductible? How much does overutilization deal with it? I don't think it's very much. So here's what we've done in our model. I'm not concerned about overutilization of the inexpensive things, of primary care, of labs, or of chiropractic, generic medications. I'm not concerned about overutilization of any of those things. Matter of fact, we actually triple the cost or the utilization of those things, because we want to decrease the utilization of the very high cost things. The MRI in the emergency room, that's the utilization I care about.
Right.
The knee replacement surgery on the 50-year-old that probably should wait another 5 or 10 years. That's the overutilization I'm worried about. But there is overutilization, and we do have some deductibles on those things. But for the everyday care things, the primary care, the physicals, the musculoskeletal help with chiropractors, the labs, the generic medications, the X-rays, the basic stuff. That's where we want to encourage utilization, but we don't want to just have it in a vacuum all by itself. We want to support that unit of primary care and the other routine everyday care services that primary care needs to be effective. We want to support it digitally, which keeps costs down, with a really robust population health function or capability that helps us get in front of problems, make sure that those asthma inhalers don't run short, make sure that the diabetic supplies are readily available to people without money. That's some important thing to do as a primary care. If you can get in front of the problem, don't let that emergency room or that admission happen. That's how we think about it. We want to utilize. We don't call it overutilization. We want the proper utilization. And right now, primary care is significantly underutilized with respect to being used to decrease the need for the higher cost hospital and medication services.
So how do you incentivize people to go to the right surgery center or to go to the right place for imaging or laboratories? I mean, do you have a network you contract with various, entities like Quest Labs, for instance, or something like that? Is that how you?
Well, we work with LabCorp, which is the same as Quest. Yeah, we work with, but and if they go there, then there's no cost for the basic labs. If they want to go somewhere else, Quest, then we'll get them the best price that we can. And it's quite often we get a better price than they can get also. When you know what the right prices are, it's harder to get duped.
Right.
If you know a baby costs $5,000, $6,000 to get delivered, it's hard for somebody to charge $30,000, $40,000 for a normal delivery. It's just a little harder, especially if we can get in front of it and prepare for it. And there's not a lot of negotiation now for us. We had to do a lot when we first started, but now that we know the pricing of things, the real price of things, we don't have to negotiate. We just have to work with doctors. And we have doctors. We are doctors. We have medical licenses in all 50 states. We have a mutual insurance company and third-party administrator license in all 50 states. So it allows us to move money really fast. It allows us to get in front of claims. It allows us to collaborate with the healthcare community around the country. And when a doctor talks to a doctor about a real person with a name, Joe Smith, who has cancer, who needs this treatment, man, a lot of reasonableness happens in the medical community. When administrators talk to one another, all bets are off.
Right.
But when doctors talk to one another about a real person with a real problem, with a real healthcare need, it gets real serious, real reasonable, real fast. I mean, immediately. And we take care of people and we figure out the pricing beforehand. And part of what we do and why it's so important that we're a third-party administrator is we are an advocate for the provider to get their money fast. And I'm sure you've been subjected to the normal insurance or Medicare audits, the normal insurance or Medicare recoups of funds that you made last year or that you made 4 years ago. I mean, it happens every day in every medical office in America. Is you get audited and then there's a recoup, and you don't just get your profit recouped, you get the whole dollar recouped. And so it's a big deal. And we spend a lot of money to avoid those audits, to survive those audits and
Right.
survive those, the chart audits and survive the recoups, because we can't afford them. We'll go out of business if we have too many recoups. We've already spent the money. Now we got to get back all of it. It doesn't work very well. But what we do with doctors and hospitals around the country is before the service, if we can, emergencies are a little different. We are going to figure out what things are going to cost, and then we are going to make sure that money gets to them fast. And it's a cleaner system. It's a system that encourages collaboration of the employer, the employees, the doctors, the hospitals. And we've created our own third-party administration company and our own mutual insurance company. So now it's easy to collaborate with ourselves. In the past, the reason we created those things is we had such a difficult time collaborating with the outside third-party administrators or the outside insurance companies. There is so little collaboration with respect to getting real healthcare done for the real price with the proper timing that doesn't scare people. So we created the parts of the system we had to, and then we collaborate with the outside parts. I don't want to create a hospital. I just want to use the hospital's emergency room.
Yeah.
I don't want to create a drug company, but I sure do want to buy their drugs for the right price.
Right.
And that's how we think about it. Again, it's a complete system that is really designed for people who have been shut out of the system. So the questions that are often asked are the ones you're asking about overutilization. Well, that's not the question that's asked of somebody shut out of the system. Right. That's somebody in the system who might overutilize. But I would ask, why is somebody overutilizing primary care? I could probably find some anyone could, some pretty significant fear that's driving that. Well, what if we, instead of putting parameters on it and high copays and a lot of rules to stop that, what if we just dealt with the fear? Find out what that person's afraid of that's causing them to go see their doctor once a month, when maybe once a quarter, maybe twice a year would be more appropriate.
Right.
Why not figure out the fear and solve that? Because and maybe it is just something as simple as teach that mom who's bringing their kid into the doctor every time they wheeze, because they're running out of their asthma inhaler, or they don't have the asthma inhaler because they're skimping on it. Maybe they're getting one a quarter. Why don't we teach her how to go to do mail order to Canada and buy 5 of them where they're much cheaper? So now she has 5 asthma inhalers around her. Attach one to the backpack, one in her purse, one in the glove compartment, give one to the teacher. Let's deal with the fear that mom has about her kid having an asthma attack without the asthma inhaler. Let's just really dive into what's going on. Common sense stuff.
Yeah.
Right? So every parent, every mom, every dad who's got a medical degree already knows what I just told you.
Right. Yeah.
Right. We don't run out of asthma inhalers. We don't run out of diabetic supplies for for ourselves, our family, but we do what our patients do.
Sure. Yeah. Yeah. So the interesting point you brought up, or I guess aspect of this, is you mentioned a mutual insurance company. So why would a healthcare plan have a mutual insurance company? That part of what is advantage that gives you to your business? Or you mentioned moving money around, but how does that
Yeah, I probably
incorporate
should.
it?
I should have defined that. Sorry, I'm in the middle of the business myself, and so I forget what everyone doesn't know. So thanks for bringing that up. So I hired a consultant um, over a year and a half ago, to help me solve this problem because I could not figure out how to work well without outside third-party administrators or outside insurance companies for the high catastrophic stuff. I just couldn't
Oh, you
figure it
mean
out.
like a right? Okay, like going to
Yeah.
the
So what we
hospital. Or
did
something.
is we
Yeah.
built our own. So a mutual insurance
Ah,
company is an insurance company that is where the owners are the policyholders. So we create an
yep.
association of businesses and people, but association of businesses. And that mutual insurance company is for the exclusive sole benefit of those policyholders. So no profit is made. Any money that's left over and for reserve is kept for reserves or to pay future claims or to keep costs down. So that is the cost containment mechanism, is to have this exclusive pool of money that is for the association of businesses that we take care of, about 1,000 of them now. And any money left over is not paid in profits. So right away, you know you've got something there, right? There's no profits are designed to come out of this. And similarly, in our third-party administrator, we're not trying to make profits. We're just trying to pay the expenses. And we
Right.
make all of our money on our membership fee. So it's about creating alignment with the purchaser of healthcare and the user, the employer and their employees, and us. We want to create total alignment. We don't make any more money if more services are done. We don't make any more money if less services are done. So having a mutual insurance company was part of that directive of our system, to be as aligned as we could possibly be with the purchaser and user of our services.
And then for your physician, if physicians you have, I mean, you cover 50 states. Are they located in one state? Are these people who sign up for, like, say, hey, I'll take care of your patients in my town? Is it
Yeah.
because
So it
I
doesn't matter
imagine it's
as
not a
much
ton.
anymore. Yeah, it doesn't matter as much anymore because digital medicine, virtual first medicine is
Yeah.
a thing now since COVID.
Yeah.
It
Right.
was a thing
Yeah,
with us
right.
10 years ago, since 2008, but with the rest of the world now, it's a thing today. It's funny how I had to explain this a lot more before COVID than I have to now. But all of our providers, for the most part, I believe, are in Scottsdale. Some of them
Okay.
we've gotten big enough now. I haven't even met some of them, so there's quite possible that. And I know we had some before which moved to another state, and it doesn't matter. We've created a part of our system is we've created a way to inexpensively get the licenses for physicians and nurse practitioners in all states much more cheaply than it used to cost, say, 5 years ago. So our providers they might live in Phoenix, but they'll have licenses in all 50 states.
I see.
And
So
it's
someone needs to
it's a little bit tricky to do it, but we've just
yeah.
created a system that does it. I mean, every
Right.
state has different rules, so knowing those rules and knowing how to navigate it. I'll just give an example. There's at least one state. I'm going to try to keep the state out because I get nasty grams if I mention a state or a company sometimes. But there's at least one state that says that every time you apply for a medical license, you have to, and renew it every year, you have to share all the information you supplied for any other medical license you have in other states. So if I've got 50 medical licenses, this one state requires me to send a lot of paperwork in. However, what if I get a new provider? That's the first state I'm going to do because then I don't have as much information to send in. I mean, I'm just giving an example of like one thing that cost me a lot of money until we discovered it.
Yes. Okay.
Right? But I'm just giving it as an example because there are hundreds of things like that.
Oh, sure. Yeah.
So it required a complex system with complex system thinking and design and engineering and complex system management, which is different than managing a simple system or just a complicated system.
Yeah, we have a federalized system, right? We have 50 insurance commissioners, and every state they have different rules for insurance companies and all this stuff, right? And scope of practice is different in every state. So if someone needs I guess the one question I always have with the virtual, if someone needs to get actually seen and physically seen, right, examined, because you can't do everything over phone in medicine, right? You have to lay your hands on people.
You can be virtual first.
Sure.
So one of the things that my wife and I noticed, two physicians, is that we started forever. Every interaction we ever needed with the healthcare system started virtually, started with a telephone call to a provider. Hey, what do you think of this? Should I be doing this? How urgent is this appointment? What if I just left it? What would happen? That's just a virtual first healthcare encounter. So yes, if you need a physical yeah, you need somebody who's got to touch you and listen to your heart and lungs and such. However, what about doing a past medical history? Does that have to be in the office? What about collecting your copay? Does that have to happen in an office? What about talking about what things are your medications are going to cost? Does that have to happen in an office? What about making sure you don't run out of your medications? Does that have to happen in an office? So we can separate, slice and dice it if we have our own system. If we're plugged into an insurance system or a Medicare system, there's rules, and you can't get paid if you don't follow the rules. So we shouldn't confuse why we have to get people to go in the doctor's office. It's so we get paid. So we follow the rules of the payer. I mentioned earlier that the payer is the one that dictates who owns the system. The payer does. Maybe it's a government in Canada, maybe it's an insurance company here in the United States, but they dictate the rules. If you get out of that system and create your own payment system, your own mutual insurance company, we can create any rules we want around our mutual insurance company. There's laws, but we can create the policies and rules that comply with the laws any way we want, which says you don't have to go see a doctor to collect a history. You don't need to walk in to see the doctor to get your prescription filled, right? We can create our own rules that make more sense. Every mom with a medical degree, I promise you, her kids see a doctor a tenth as much as she recommends for the same condition for her patients, because she's got resources. She'll call up another doctor. She'll call up a friend and go, hey, my kid's doing this. I'm sure it's just this. It's not, pink eye, she'll deal with herself. But maybe it's pink eye's not getting better. Yeah. She'll go call the specialist herself, but she's not going to go book an appointment. She'll call first, get some advice, try that advice. And the chance of her going to see that doctor for that pink eye that's not getting better is probably a tenth as much as what the healthcare industry that she would recommend to her own patient. So we've done a lot of biomimicry around what would a mom with a medical degree do for her own family. It's just biomimicry, right? Suction cups.
Right. Sure.
We just copied it and we built it into the system because the people we're taking care of, they don't have time. If I take somebody off work for half a day who works in a car wash, my gosh, the chance of them being able to easily afford their rent that month, it was already too hard. Now I just made it maybe impossible because of one doctor's appointment for their child. And it's just, if we really pay attention to the market that we're serving, that's not the Medicare market, that's not the Medicaid market, it's not the big corporate jobs or government jobs. I'm talking about small businesses, car washes, dry cleaners, restaurants, retail, construction, trucking companies. I mean, I'm talking about normal people.
Yeah, right. And then pharmaceuticals are obviously a big problem, and pharmacy benefit managers, we talked about a lot of times in this show about, we'll call them rebates, kickbacks, whatever you want to call them, but that's how they make their money, right? Yeah. Did you form your own PBM, or did you just find some of the 10% PBMs that don't skim so much money off the?
I'd say I worked with I think 4 totally transparent pharmacy benefit managers I had to fire because they were totally transparent. Once I asked them, they showed me how much they ripped me off every time. So they're transparent about how much they ripped me off for sure. But the deal we've got right now is incredible. So we pay through our pharmacy benefit manager, we pay only the cost of the drug. Contractually, it would be a problem for them if there was anything besides the cost of the drug being paid, and we pay a transaction fee on behalf of our members.
Right. Okay.
That's how we do it. And the rebates that only happen for brand name drugs, of which we order, I think we're about probably 4% brand name, but the rebates on those by 4% totally pays the transaction fee. So we just stripped out the unnecessary. Actually, I believe the problem with healthcare, if I really were to nut it out, was complexity and hidden costs.
Oh yeah, no question. I think you're right.
And so if I solve those two problems, a simpler system, but it's still complex, but it's just simpler, and I get rid of the hidden costs, the middlemen, the things that just don't create value, just get rid of them. That's the basis for creating any kind of healthcare system. If you want it to be simple and truly affordable for everyone in a company or everyone in a family, if you don't think about it that way, I don't know how to do it. Somebody else might figure it out. To date, I haven't seen anyone do it, but a lot of times they're thinking about the problem. In my opinion in a kind of a silly way. I mean, we want to think of, it's so easy to think about the problem of in a political sense, or if it's just these people would take care of themselves, and if it's all the smokers that are raising our costs,
Yeah,
or it's
right.
overweight people raising our costs, or it's the people who won't exercise that are raising our costs. I mean, there's a lot of judgment out there about why costs are going. The overutilizers is right. It's there's a lot. There's truth to all of it, but it's not the whole thing. It's a small little, tiny little part of it working together to increase costs. But if you think about who's driving those narratives, it's usually the insurance companies.
Yeah,
It's
sure.
usually and the only one that benefits. Look at who benefits, who makes money off of that, and you're probably going to find who's driving the narrative.
Yeah, no question. I mean, when you look at the amount of, I mean, there's at least 40 to 50%, I think, of healthcare costs are spent on people who are providing no value. We couldn't have designed probably a more expensive healthcare system than we have in this country. And it's driven largely by people who profit from that. And they use that money very wisely to lobby to maintain the system as it is, right? I mean, through legislation and regulations at the state and federal level. But I think,
So here's your nice little experiment for your listeners that I don't think will get me in trouble because I won't mention any names. Go pick any insurance company that is a name brand that you know, and pick 3 of them, 4 of them, 5 of them, if you can think of them. And then go to Google and look up their stock price, pre-Affordable Care Act and today. So look at it, like, let's say about 2007, 2000, that's when they're, and look at 2004 to 2007, and look at their stock price. Now look at their stock price from then till today, and just see what happens to all those curves. And you'll see who's driving the narrative, who the Affordable Care Act was really designed by and for.
Yeah.
And just forget the narrative you hear in the news or you hear it, right? Just look at the money. Then the money will tell you what the real narrative is and who's driving it.
No question. I mean, when you're looking for solutions in healthcare, you're not going to find it through legislation. I think that's almost always the case. Problems are not solved by that. They're solved by the market, people finding innovative ways to fix it, like you have, right? And like lots of people I've had on my show who are finding workarounds, and despite all the barriers, you're finding ways to deliver care. And because now it's actually almost easier to do this because the price differential is so big. It does, you can, if it's only like 3%, you can't make a business to save 3%. But if you can save 40%, well, now it makes sense to create systems that work. Yeah. So your Redirect Health, who are your clients? Who are the people who need to look into this sort of thing? You say small business. What does that mean? Does that mean someone who's got 150 employees, or is that, I never know what small, medium businesses are. Yeah. I know what a large business is.
Neither do I. Here's what I do know. The range that we've got is 2 employees to 1,500. That's our range. Now,
okay, that's
we've got some folks that are in the tens, thousands looking at us right now, and I don't know they really fit our criteria. Well, maybe they do. We'll see. But it's less about the size of the company. It's more about the leadership of the company. And because I've seen large companies where the leadership thinks the way they would need to use our system, and I've seen 10-person companies, and the leadership can definitely not fit. So let me give an example. If there's a small company with 10 people and they come to us and the owner says, no, I just want to take care of my family and these 2 managers. Bad fit. They don't want everyone in their company. Right. They'd be better off on a regular insurance product. But I could get somebody with 5,000, 10,000 people, and I've got the leader, the CEO going, hey, I got to make this work for all of my employees. And my job is strategy as a CEO. My CFO's job is just making sure I have the money for my strategy. And my HR department's job is to make sure they communicate our health plan so it gets used properly by our employees. That teamwork is there, and I'm the CEO, and I'm going to drive it. The strategy is mine. Don't touch strategy. That's mine. I'm the CEO. If I get that guy, that company, I don't care how big you are, it works. Our system works. It's when the CEO says, I don't care about everybody, and man, this isn't my job. That's my accountant's job, my controller's job. That's my HR manager's job. My broker, my HR figure that out for me. I don't care how small you are. You can't be a client of mine. It won't work. It's not designed for you. It's designed for very thoughtful business leaders who want to solve a problem, meaning the complexity and the unaffordability of healthcare for all their people. So they want simple and truly affordable healthcare for all their people. If I find a leader who wants that and wants to own the strategy around that, that's where we fit really well. Because the other part of this we haven't talked about is any leader who takes care of the burden of healthcare for their normal workers. Oh my gosh, they have a business advantage. In my business, I go free healthcare entire family. Thousands of resumes of really good, ambitious, like loving, caring, smart, thoughtful people who don't want this burden. And because they're not just there to remove the burden of their own family, of worrying about access and affordability of healthcare. The people who we attract, they also are somewhat intrigued by a company that can do that and wants to help other families. So these people that work for me also want to help other families remove this fear, and they get it because they're right there. But that's us leveraging our ability to get healthcare costs so low, to get healthcare working so well that we can give it away for free, and then we can attract the best employees, the best team, and then productivity goes up and it pays for itself. We have construction companies that join our association or join our club, if you will, and get our healthcare, where their workers' comp costs are so high because they don't have workers' comp is a form of healthcare. But if you don't have regular healthcare or work comp becomes a de facto healthcare for your people, don't be surprised if that back always goes out on Monday, never on Saturday, right? Just don't be surprised. It's logical. And but if you've got first dollar coverage for your health plan, you don't have to use workers' comp for that little cut on your finger that needs one stitch in the urgent care. You don't have to. If it gets infected, you do. Or you sprain that ankle, it's first aid. You don't have to use workers' comp. Of course, you break it, you should. You do. You have to. But you have a lot more choices for these construction companies. And what happens is within 2 years, their workers' comp costs get pretty much down the minimum levels. And many of our clients, their workers' comp savings, which is bottom line savings, 100% pays for the healthcare they pay to us to join the association, to be part of our plan. And so it's really just about thoughtful, strategic thinking of the business leader. And sometimes that's an HR person, sometimes it's a CFO or controller, but it better be all the time the CEO.
Yeah, makes sense.
That's my opinion on it. I guess there's lots of types of business, but the businesses that work best with our system, there is a very thoughtful CEO or leader involved.
Yeah, no, I imagine so. Well, Dr. David Berg from Redirect Health, aside from going to your website, in which will all be located at the show notes page, theparadox.com/151, where else can they find your stuff, writing, social media, et cetera?
Well, if you want to get a copy of the book, go to redirecthealth.com/ending the fight, and then you get a copy of the book.
Okay, great.
And otherwise, our website directs people around. If anyone wants to contact me directly, it's david.berg, B-E-R-G, like iceberg, @redirecthealth.com.
All right. Well, hey, thank you so much for being on The Paradox. I appreciate it.
Oh, my pleasure.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.